Good morning. Welcome, and thank you for joining us for our Northern Light Health Good Health is Good Business Zoom conference. Pandemic fatigue. Everyone in their own way is done with this pandemic, yet the fight goes on. While we are resilient creatures, our reserves have been nearly exhausted. We hear about increasing suicides, increasing drug and alcohol use, not enough staff to take care of people in hospitals, leading to hospitals closing beds when more beds are needed. Mild disease with Omicron is our great hope, our great misinterpretation. COVID-19 deaths continue, and Omicron is quite the formidable foe. We'll look at these issues today, but I'll start us off with the bottom line. In spite of all the pros, all the cons, all the politics, all the challenges to figure out what to do, boosters offer our best countermeasure. Today, our topics will include the latest on COVID-19, COVID-19 boosters and vaccines, pandemic fatigue, and strategies to support your team. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Beacon Health. I'll be your moderator for the next hour. Our panelists today are Dr. Rebecca Gass, Physician Lead Infectious Disease Care Co-Director of our Antimicrobial Stewardship Program at Northern Light Eastern Maine Medical Center. Becky DeCoyster, Senior Manager of the CDC COVID-19 Contact Tracing Program. Yamaya St. Clair, Employee Assistance Program Counselor at Northern Light Workforce. Dr. Jim Jarvis, Director of Clinical Education at Northern Light Eastern Maine Medical Center and Physician Leader of COVID-19 Incident Command at Northern Light Health. Before we get started, I will read our legal disclosure. The coronavirus pandemic is an ongoing, continuously evolving situation. Northern Light Health encourages everyone to follow federal and state governmental guidance and mandates. Northern Light Health does not know the particulars of your situation, so the information presented today is general in nature and is based upon Northern Light Health's own experience, which may or may not apply in your specific situation, and which may be revised as we learn more about the coronavirus. Accordingly, following any guidance Northern Light Health presents today in no way guarantees that you, your employees, and/or your customers and clients will not contract or spread the coronavirus. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Dr. Jarvis will start us off with the latest on COVID-19. Dr. Jarvis?
Thank you, Ed. The next slide, please. So I really wanted to stress that while we talk about some optimism around the coronavirus pandemic, particularly that we're seeing in certain places around the globe and here in the United States some waning of disease, the disease prevalence in the state of Maine and in most of the world is still quite high, and that the death from Omicron is as high, the daily death rate in the United States is as high for Omicron as it was for Delta. And so we're seeing almost 2,000 deaths per day in the United States. And so this is still a deadly disease. New slide, next slide, please. I really want to focus in on this graphic. So this graphic is based on Northern Light Health's inpatient volume. And what you can see is we've had some shift since we've shown this graphic in the past. Really, when we start looking at hospitalized patients, if we look at those that are just in the hospital and not those that are in our intensive care or our ventilators, we can see that almost half of them now are individuals who are vaccinated. I want to be clear that our definition of vaccinated for this graphic means that they have received at least one vaccine dose. So it doesn't mean that they have completed a vaccine series and does not take into effect whether people are boosted or not. But if we look at the numbers there, when we look at those under the age of 60, that's still a significant number of people who are unvaccinated under the age of 60 who are hospitalized. And then as we shift to looking at those that are in our ICU and our ventilators, we see that, again, we continue to see that those who are the sickest are those that are unvaccinated And that's really where the concern is. When we talk about, though, that nearly half of the patients that are in our hospitals are vaccinated, we must remember that here in the state of Maine, upwards of 78% of all Mainers now are fully vaccinated, and over 50% of those individuals have received their booster. So that is a much larger pool than the unvaccinated population. And so if vaccines were not working, we would expect to see that vaccinated people would actually outnumber those that are hospitalized. But what this does state is that the Omicron variant is so much more virulent, meaning that it's, infectious, meaning that it spreads from one person to another more readily, that we are seeing that larger population of people who are vaccinated also being infected, and some of them requiring hospitalization. The good news is many of them really only have moderate disease, and their length of stay in the hospital is less. And as you can see, they are less likely to require critical care or ventilatory support. Next slide. Is that yeah. And then this lastly just kind of depicts that in the state of Maine, we still continue to see spread across all counties in the state of Maine. Every once in a while, one will pop up a little bit harder than another. I'll remind everybody that when you start looking at national data, that the state of Maine, unfortunately, is behind in its case counts and it's reporting to national databases. And so predictive models for the state of Maine probably are not as accurate as we would like based on the current conditions. And so we need to take all of those with a grain of salt. I think that's my last slide.
Yeah, well, thank you, Jim. Next up is Dr. Gass, who will help us understand the role for vaccinations and boosters during this Omicron phase of the pandemic. Dr. Gass?
Thank you very much, Ed, for inviting me today to hopefully give a little clarity for the overwhelming amount of information that's out there on Omicron boosters and vaccines. I first want to give my disclaimer that everything I say today is up to date as of today, January 27th, but could change by tomorrow or maybe even by this afternoon because our data is coming in so fast. So why are we here? Well, when viruses replicate, they mutate. And when those mutations present a selective advantage, the viruses that carry them will spread. Omicron was first identified on November 11th in Southern Africa. And by November 26th, it was actually declared a variant of concern by the World Health Organization. And subsequently, it spread worldwide faster than any prior variant due to these selective advantages. In the US, the first case was identified at the beginning of December. And as of this week, Omicron accounts for more than 99.9% of the cases in the US that are sequenced. So why did this happen? Well, Omicron has more than 50 mutations, and it has more than 30 on the spike protein. And the spike protein is how the virus attaches, penetrates, and infects our cells. It's also part of the virus that we've used to develop vaccines and our therapeutic monoclonal antibodies. So these mutations have resulted in increased transmissibility and, more importantly, immune evasion. And these two factors have led to the unprecedented spread of this variant. Next slide, please. So let's look at transmissibility first. The doubling time of Omicron is 2 to 3 days, and that's in comparison to a 7-day doubling time for the Delta variant. This virus's mutations allow for more efficient cell entry and increased infectivity of cells. Some early data had showed that perhaps there were higher viral loads with Omicron, but this does not appear to be the case. The R0 for Omicron is greater than that for Delta. And what that means is that one person infects more susceptible individuals with Omicron than with Delta. And household transmission risk is 3 times higher with Omicron. And I think we're witnessing that in our own households and those of our colleagues and our friends as we see the virus work its way through families and households. Next slide, please. So as I said, immune evasion is probably the most important factor in the spread of this variant. So antibodies, which are what we hear a lot about in the news, because they're the easiest piece of the immune system to study in the laboratory, they protect against infection. And what we know is that antibodies appear to wane and work less well against the Omicron variant. This includes the antibodies that develop from natural infection, What they saw in South Africa was more than 70% of their Omicron cases had actually been previously infected with another variant. And the risk of reinfection with Omicron is 5 times that of other variants. Of the 3 therapeutic monoclonal antibodies that have been developed, only one, sotrovimab, actually retains activity against Omicron. And finally, we're seeing that the antibodies that our bodies build as a response to vaccine are waning and are less active. So again, as I said, neutralizing antibodies are the first line of defense against a pathogen, and that prevents infection. So what we've seen in the lab is that the levels and the effectiveness of antibodies drop significantly over time against both Delta and the Omicron variant. But what we do see when we look at the blood and the antibodies of patients who've been boosted is that the amount of antibodies and their effectiveness increases significantly after boosting. We also see improved levels and effectiveness in those persons who get vaccinated after they've been infected. And as well, we see this boosting effect after a breakthrough infection in vaccinated persons. Now, how long this antibody effect will last is really unclear at this point in time. Preliminary data out of the lab would show that this improved levels and effectiveness last at least 4 months. But remember that antibodies are not a direct indication of vaccine efficacy. They're only one piece of the puzzle. The other part of our immunity against viruses is our T cell response. And this is the part of our immune system that's much harder to study in the lab, and it kicks in after infection has occurred. It's the T cell's job to eradicate infected cells and to prevent end organ damage. And this is what prevents against severe disease, hospitalization, and death. In the lab, T cells actually recognize more than 80% of the targets on Omicron. And this is why our vaccines, although maybe waning in effectiveness against infection, actually still provide effective prevention of severe disease and death. And after we boost, the T cell responses increase in quantity and in breadth. And this will probably result in improved response by the T cells to new variants when they occur. Next slide, please. So what does this mean in the real world? So there's been 3 really good studies that have been released in the last week, and I have a couple of slides from these studies. This looks at rates of COVID infection based on vaccine status and boosters. And in the blue is the time period where Delta predominated. In the pink is the time period where Omicron became the dominant strain. And what you can see is in November, as we got farther away from when most people received their first vaccine series, we started to see an uptick in cases. And this really took off once Omicron became the predominant strain. But what is quite striking is the difference in the rates of infection in the unvaccinated, represented by the black line at the top, compared to those persons who received a primary series of vaccines, which is the dotted line, and an even improved benefit for those persons who were boosted. In December, the risk of infection with COVID was 5 times greater for the unvaccinated compared to those who were vaccinated and had received a booster dose. Next slide, please. So this is a slide that looks at vaccine effectiveness against severe disease. And basically, admission to hospital with COVID-19 is a marker of severe disease. On the top line, the blue line looks at vaccine efficacy against the Delta variant. And then the red line, it's the efficacy against Omicron. And what you can see is that once we get out more than 6 months after a vaccine series, the primary series, which for mRNA vaccines is 2 doses, we see a drop off in effectiveness against preventing hospitalization for Delta, but even more so for Omicron. But what's impressive is that after a 3rd dose or a booster, we see effectiveness that actually is greater than that which was provided by the original vaccine series. So for Delta, protection goes from 90 to 94%. And for Omicron, it goes from 81 up to 90%. So our vaccines work well against severe disease, but they work even better after a booster. And this data has been replicated in several studies. Next slide, please. Dr. Gilkey brought up the concept of Omicron being a less severe disease. And I really want to talk about this because I think this is a narrative that needs to be explained and debunked. So what's really going on? Well, in the lab, it appears that Omicron causes more infection and more damage in the upper airway, the nasal passages in the throat, and seems to have some degree of lesser lung infectivity than prior variants. So there's something about the virus that's a little different. The other factor, though, is that we have to remember in our population, we have immunity now from vaccines and from prior infections, which is also affecting the severity of what we're seeing with Omicron. Data from South Africa, the UK, European countries, and most recently from California, Kaiser Permanente, is showing lower hospitalizations, shorter hospital stays, and lower death rates. But there are some caveats for that. Deaths lag behind infections and hospitalizations. And as Dr. Jarvis indicated, our death rates are higher than they've been at any other point in the pandemic. The other thing is that populations aren't necessarily directly comparable. So what happened in South Africa or in the UK or Europe may not happen here. The US population is much older than the South African population. The US population is less vaccinated than the EU and the UK. As of January 25th, the fully vaccinated rate in the US was 63.8%, and in the country as a whole, only 25.8% of eligible persons have received a vaccine. The other factor is that the US population has a high incidence of underlying conditions that predispose to severe disease. So although Omicron may cause less severe disease than Delta, it is not a mild disease. And I can tell you that from firsthand experience, what I am seeing in the hospital right now. It is most particularly severe, and those at greatest risk for severe disease are the unvaccinated, the people who can't respond well to a vaccine, so the elderly and the immunocompromised, and then those with underlying conditions. The bottom line is that the proportion of severe cases may be less, but given the sheer numbers of infections that we're seeing, it's overwhelming in terms of our hospital system. And I also want to make a point about the long-term effects of COVID. And we have no data on Omicron, which has just been with us for 3 months at this point. We have to think about long COVID, the after effects of damage to the lungs, to the cardiac system. What about children? We're seeing unprecedented numbers of cases in children. And what are going to be the long-term effects of this? What are going to be the long-term effects on our healthcare system with the exodus of frontline healthcare workers and the effects of delayed non-COVID care? Next slide. Which is up already, great. So I think I've just given you a myriad of reasons why we need to continue to try and mitigate the effects of the pandemic. And we also have to remember that when we allow viruses to transmit, they replicate. When they replicate, they mutate, and this will lead to new variants. So what can we do? Well, the non-pharmacologic interventions still work. High quality masks, distancing, ventilation and air filtration, hand hygiene, staying home when we're sick, vaccinate. We need to reach those people who have not had their first series of vaccines, and we need to encourage boosting, which will better protect against infection, will increase protection from severe disease and death, as I have shown, and will disrupt transmission. Thank you.
Thank you, Dr. Cass. We'll now address some clinical questions with our two physicians. Jim, if you would join us. So this question is for Dr. Gass and Dr. Jarvis, starting with Dr. Gass. At this point in time, what is top of mind for you relative to the pandemic?
That I wish it would end, to be quite honest.
Check.
Uh, but I think we have to acknowledge that we aren't at the end and we don't know what's going to come next. And that anyone who would predict the future or say that we're at the end, I think is on a fool's errand. I think we really need to work on vaccination and encouraging boosting and vaccination in the US. But also I'm concerned about global vaccine inequity. As long as we have uncontrolled transmission anywhere in the world, we're at risk of a new variant coming.
So the pan in pandemic is everyone around the world.
Exactly.
Yeah. Jim?
Yeah, so I share Dr. Gass's sentiments. I think for me, the focus really is on, have we learned our lesson? And what will we do with the next event that occurs? There are some promising news about the pandemic that we're currently in, but I agree with Dr. Gass that we can't be overly optimistic. We need to keep our guard up. But what we've seen in the past is, as soon as we start talking about things getting better, people have let their guard down. They stop wearing masks. They start to congregate again, and then we see yet another surge. And then, of course, have we learned our lesson in terms of preparedness for the next pandemic? Because there will be another one, and there's no doubt about that. It's just a matter of when it will occur. And have we given enough thought to rebuilding our public health infrastructure? Have we talked about providing better education so that we don't see the divisions that have occurred in terms of information, misinformation, and sometimes flat out falsehoods about science directive and data-driven analysis and proposals, and so those are the things that I think are on the forefront of my mind.
Okay, well, thank you. Dr. Gass, I have an audience question for you. Actually, it's a double question. Does the spike protein in the vaccine transfer from nursing moms to infants? Is there any risk to the nursing infant?
So the spike protein itself doesn't transmit. What does transmit across the placenta and in breast milk is the antibodies that are produced by the mom, and that provides protection to the baby. And as we know, children under the age of 5 can't be vaccinated. The spike protein only sticks around for a very short period of time, but the transmission of that protective antibody through breast milk is very important.
So I'll take that question a step further. So has the study shown any downside for getting a vaccine for either a pregnant or a nursing mom?
No, in fact, we know that pregnant women are at higher risk of more severe COVID disease and for poor pregnancy outcomes. So just like with influenza, it's very important that we encourage our pregnant women to be vaccinated. And that peripartum period, so the postnatal period after birth, is included in that. So nursing moms as well, if they haven't been vaccinated.
Great, thank you for that. Dr. Jarvis, I have one more question in this section. Where do we stand as a state on the supply of monoclonal antibodies, the oral medications, and could you mention the role of remdesivir during this time?
Yeah, so Ed, that's very good. So all of those things that you mentioned are treatments for people who have mild to moderate disease and have risk factors for getting severe disease. And that's really what we're talking about, is trying to prevent people from being hospitalized, requiring intensive care, and unfortunately dying. The problem we have right now is that because of Omicron and its uniqueness, only one of our monoclonal antibodies is shown to be effective, and that's sotrovimab. We do have a supply of that, but that supply is very limited. It is mostly given by an infusion, meaning that you have to have an IV started, and so therefore there's that complication. Similarly, the oral antivirals that are now available are also extremely in short supply. And unfortunately, the rollout that the state had used by using Walmart and Hannaford's as a distribution point, because of the low supply, really has not met the needs that we needed to. And the state is right now undergoing a look at trying to change that supply chain so that we can get it to those who need it the most. Remdesivir is one that we actually have in good supply. The drawback to remdesivir is that it also is an infusion, and unfortunately, it's 3 consecutive days that you have to get that infusion. So it's very time consuming, and obviously transportation issue for many people can be a concern, but it can be a life-saving thing, particularly for those people who are extremely high risk. The state continues to work with the federal government to increase the amount of sotrovimab that we get into the state, as well as the oral antivirals that are now available. Unfortunately, nothing is the panacea. Nothing will be the savior for all of the things that we're talking about. And really waiting to get a treatment after you've been infected is really too late. What we want to do is prevent that infection in the first place. So again, strongly encourage those who have not yet chosen to be vaccinated to get vaccinated, and those who are eligible to get their booster to get boosted.
Yeah, thanks, Jim. I think I'll weigh in on what you're saying there as well. I'm hearing maybe too often people thinking they should get infected with the Omicron now, get it over with. We don't know enough about it to know genetically who's going to be at the highest risk for a severe reaction resulting in hospitalization and perhaps even death. We do know that there is some correlation with age, but that's not the whole story. So the rest of the story we don't really know. So that's not advised to go out and get the Omicron and get it over with. And then those 2 oral antivirals, they're not the magic bullets, and they are in very short supply. So not to count on that. I would say, thankfully, we have remdesivir, so that's kind of like some saving grace in all this. But as you pointed out, Dr. Jarvis, that's not the easiest, to infuse and get it all done. And then the monoclonal antibody, we only have 1 at this point out of the 3 that we had, and that's in such severe supply, shortage that we can't count on that for any given individual neither. So that should be taken into consideration. Well, thank you, Dr. Gass and Dr. Jarvis. We're going to switch to our next session. Dr. Gass and Dr. Jarvis will be joining us for more questions and answers in the latter segment of our program today. Next is Umaya St. Clair, who will take a deeper dive into pandemic fatigue and how to support your teams and nurture a culture of caring. Umaya?
Thank you so much for having me. While it goes without saying that the past 2 years have been stressful for employees, new research suggests that managers should say it anyway. The challenge for many leaders is how to really open up the conversation authentically. The easiest solution is often the most overlooked, and that is to be really available and present. This is, of course, harder than ever right now when leaders are navigating ever-shifting and expanding roles and responsibilities, sometimes leading hybrid teams. Leaders who do understand the value of being available have come up with some pretty unique solutions. I've heard from leaders who hold daily or weekly office hours, others establish routine, quick check-ins with employees, and some just clearly articulate the hours when they will be available via phone or text, of course, as well as those when they can't. I encourage everyone to really consider in what ways you're accessible. When an employee does reach you, are you able to minimize distractions and offer them your full attention? I realize this isn't always possible, and for those times, I encourage you to acknowledge that. A simple statement such as, "This conversation is really important to me and I want to give it my full attention. Can we schedule a time later today when I'm less distracted?" That goes a long way, just assuming you, of course, do schedule that time and make it happen. Once you are able to give someone your full attention, open the door to all forms of conversation, even the more difficult ones. I've heard managers express concern that they'll really kind of open Pandora's box to a fruitless venting session if they ask open-ended questions and give employees the floor. Research suggests otherwise. Studies recently published in the Journal of Organizational Behavior looked at acknowledging others' emotions in the workplace and found that the trust that comes from verbally recognizing how employees feel, particularly when they're sad, upset, or angry, it really helps form a much deeper connection and build that trust. This kind of validation also relates to a concept I've talked about previously on this panel, and that is psychological safety. It's one of the strongest predictors of team effectiveness. Employees working within psychologically safe cultures perceive they can take interpersonal risks, such as speaking up, admitting a mistake, acknowledging confusion, and even offering a dissenting opinion without being risk of punishment or rejection. And you can really promote this kind of culture by acknowledging how challenging the circumstances are, owning and vocalizing how you can improve, and by thanking others when they do speak up or admit a mistake. All of this helps build trust and ultimately that loyalty we want from our employees. We've heard from a lot of leaders recently expressing that the tough calls they've had to make amid rapidly changing conditions have eroded trust with some employees, and they're really wondering how to build that back. The first step is, of course, to take responsibility, acknowledge actions that negatively affected employees, including any unintended impacts. This really demonstrates that you recognize your decisions have had real consequences and you're aware of what employees have endured. Next, explain why you made the decisions you did, not in a defensive way, but in a really transparent way, providing the context around why a decision was made, the alternatives you weighed, and how difficult it was for you to make those tough calls, knowing employees would be impacted. And lastly, really offer to make repairs and develop action plans based on employee feedback, using direct input from employees about what they need. This may seem obvious, of course, but in a recent study, 66% of executives reported they developed their post-pandemic workforce policies with little to no input from employees. One of the repairs employees may need or request is just some additional support addressing personal concerns that may be impacting their work. If you have resources you can offer, such as an employee assistance program like Workforce, have those resources readily accessible. I'm so pleased to introduce a leader today who I think does an exceptional job of opening up conversations with employees. Becky DeCoyster is a senior manager with the Maine CDC, leading the COVID-19 contact tracing teams. As you can probably imagine, employees on that team have had incredibly stressful and ever-changing work over the past few years. I met Becky when she requested a facilitated group for her team, recognizing that they could use some additional outside support from us at Workforce EAP. So Becky, welcome. It's so great to have you here.
It is wonderful to be here, and thank you for having me. It's good to see you again.
Yeah, you too. Can you just tell us a little more about your professional role and the team you lead?
Absolutely. I am the program manager for the contact tracing program. When we say contact tracing, often people think of the whole package, from talking to people who have tested positive all the way through contacting the folks who had been, a close contact of those people. In Maine, those are two different functions performed by two different teams. So our sister team calls the positive test folks and talks them through that and elicits the contacts that we receive. So we have been fully remote for the duration of the pandemic since I think April of 2020. And over the months, we have fluctuated in size from about 60, maybe a little bit more than 60 at our largest point to, 15 to 20, depending on, the surges that we were encountering. So we are cold calling people, essentially cold calling people as representatives of the state government, and we're telling them unpleasant news. and then we would ask them to enroll in symptom monitoring. So it's a delicate conversation, and our contact tracers are having that conversation throughout the day, multiple times, dozens, hundreds, thousands of phone calls.
Wow, what an incredibly important and challenging job. Can you talk about some of those challenges? What are some of the primary challenges your group has faced?
Absolutely. Surprisingly, being remote is not one, and probably because we started that way. We didn't have that transition. Our challenges have more related to a couple of discrete areas. First, staying on top of new information and recommendations and the workflows that we have to change and adjust for different surge levels. So we want to be an information source for the people that we're talking to, and we want to give them good and up-to-date information. So it's constant education. And then I would say the larger challenge relates to the nature of the calls. As you pointed out, pandemic fatigue is real, very real. And we get a front row seat to the myriad ways that Mainers are coping with all of these feelings of, frustration, fear, anger. And so for the team, it can be difficult to stay emotionally present and resilient through all of that. They're absorbing a lot, and we need to make sure that they're supported in that work.
Yeah, definitely. So how has morale really fluctuated throughout?
Wow. We are essentially a microcosm of Maine as a whole, right? We're Mainers, we're feeling the same things that our fellow citizens are. And I started thinking about, big picture, sit back, and we've been through 2020 and then 2021, and now we're entering 2022. And there have been, you can measure the differences in many ways, case counts, new variants, all of these things, lockdowns or not. But if you look at it, its impact on the emotional, psychological, spiritual life of Mainers, there have been phases. And so initially in 2020, there was that sense of urgency and maybe a little bit of fear, maybe a lot of fear. We were cheering for the healthcare workers. There was a sense of we're all in it together. And then we enter 2021 with vaccination on the horizon. And we have always known that we are trying to work ourselves out of a job. We felt very hopeful when vaccines started to roll out. And then over the fall and winter, that 1-2 punch of Delta and then Omicron, right before we had really declined from the peak of Delta, it has given rise to a lot of frustration and sadness and in many ways grief for all of the different changes and types of losses that we have all experienced. So as I say, the team is living through this in the same way that we all are, that the folks we're calling are. So
Yeah, thank you so much. And I think about grief a lot and talk a lot with clients about that through this. And I really try to normalize that process for people because it is a lot of what many are experiencing. And I wonder just how do you keep a pulse on how your team members are doing?
We build in a good amount of routine. So we have a 15-minute morning meeting and a 15-minute evening meeting to kind of just respect the boundaries of our day. I think that's important for a remote team to have I'm at work and then work ends. And I try to attend these regularly to kind of stay on top of how the team is feeling, not to lead them or facilitate or even contribute, but just to be there and be seen and be listening. So I think it's very important to be present in that way as a leader, as you sit back and let your team lead. I do a lot of one-on-ones, which you touched on, and I know this gets harder the larger your team gets, but pretty much every day I'm doing 1 or 2, they range anywhere from 5 to 15-minute chats with my team, just in a rotation right through the list. And actually, I think a lot of them were not used to that. Because initially I'd set up these calendar appointments and it was creating a fair amount of nervousness. I'm getting called into the boss's office. So we talked that through and I said, no, this is, I just want to see how you're doing. And so it's now just a regular thing and they don't panic when they see me pop a meeting onto their calendars. They know it's just a check-in. Okay. So those are just some ways that I try to keep, a sense of how things are going for them.
Yeah, wonderful. And, my colleague Ariel and I facilitated a group discussion for your team a few months ago. Can you tell us about that experience from your perspective? What led you to call for that and what feedback you heard from team members?
I would be happy to, yeah. It goes back to grief, which we've been mentioning. I was in a different meeting and I believe one of your colleagues, maybe Eric, identify grief. Like I hadn't heard anyone yet talk about that as a name for much of what we were all feeling. And so I decided to pursue that. I knew that my team was feeling, a little down, dealing with a lot of big emotions. not only at work, but in their personal lives. We all have family members who maybe think differently than we do about things, about the vaccines and whatnot. And so we had good communication channels internally. We're very good at supporting one another, but it was just very powerful to have you and Ariel come in, provide facilitation, hear and support and acknowledge those less positive, scarier feelings that maybe we don't feel comfortable putting on the Teams chat, or saying in the evening meeting when we're debriefing together. So it was incredibly important to create that space and provide that, and that it not be me leading it. This is for us. This is for you. It's not boss, employee. It's none of that. It's just, we're in this together, right? And I have to say that you and Ariel are just marvelous facilitators. I really think it was one of the best led sessions I think I've encountered in my professional life. And so many of my team members spontaneously chatted me afterwards to say that they were grateful to have that space to share and be heard without judgment. And then some of them didn't participate, but it was nice to be there and bear witness to folks who were sharing. And so it was, I can't say enough about what a positive it was for the team as a whole.
I'm so glad to hear that. And it was a real honor for us to be able to support your incredible work. And I guess my last question is just what tips do you have for leaders who are looking to open up dialogue with their teams?
Wow. You've hit on many of them. I think, being available and being human. And if you don't have those regular check-ins set up right now, it's not too late. You start, and then if they're nervous to have a check-in, you work through that with them. But I think being human is a foundation to building the kind of team morale and trust that we all, I think, strive for. Don't wait for them to ask for help. It's hard to ask for help, and so I think those touch base meetings are a nice private space where they don't have to take that scary step of being vulnerable and saying, hey, can I take a part of your day? It's me saying, hey, I've got a part of my day I'd like to give to you. So don't wait for that. And then I think the last thing ties into that. Don't wait to ask for help yourself, right? I mean, we're creating these strong, supportive cultures, but none of us can do that alone, right? And sessions like you guys provided created just a space for a healing that we would not have been able to create or provide on our own. Certainly that I couldn't have done for them. So thank you for that. And those would be my tips.
Thank you so much. You lend such an excellent perspective to this conversation. Your team is fortunate to have you at the helm. So I appreciate your sharing your expertise with us.
Thank you. Thank you very much.
Mm-hmm. All right. Well, I think we'll turn it back to you, Dr. Gilkey.
Well, thank you, Maya. Thank you, Becky. Now our entire panel will address further questions. And Dr. Gass, if you would join us as well. So Becky, thanks so much for sharing that inside information with us. I'll let you in on a little secret. You're awesome.
Thank you.
So from your experience, what does it look like when an employee seems to be having problems?
And I was a teacher in high school, and I think it's kind of the same thing. You look for the loud person being a little more quiet, or maybe a little more boisterous. Or I have one staff member in particular who has a very wry, sarcastic sense of humor. And when that person is feeling especially stressed, that kind of tips into a darker sense or expression that kind of triggers me that I need to check in with them. And I think those are changes in their behavior. If somebody's always quiet in your meetings and prefers to have their camera off, that's okay, but you want to make sure to be staying in touch with them, especially because you're not seeing that visual feedback every day. So I think those are some top of mind thoughts.
You know, I'm thinking what you're telling us is it's really about knowing your people, relationship management. And when you start seeing something change, time to probe.
Yeah, you can even see it. I'm sorry, in their
Yeah.
comments on Teams. We use Teams as our communication channel. Like you can look at that, and at this point, months, so many months with them, I can kind of get the sense of their conversation without me participating or
Yeah.
doing anything at all. So I think paying attention is just really important.
So Becky, I have another question, and it's a bit of a nuanced question based on information that Yamaya shared, and then some of your response. So I'm trying to drill down with this question, actually a series of a couple questions. So whatever way you want to answer it, but how did you decide it was time to engage Yamaya and Ariel from Workforce? What helped you to recognize that time? I mean, I heard about your exposure to Eric and, it started the wheels turning, that kind of thing. What signs did you read in your staff where you said, it's time to go in a somewhat different direction here? Like you were talking about reaching out for help. You decided that at some point. Like, how did you figure that all out?
It was putting together those two things that I mentioned, like my check-ins with them, their individual responses, the tenor of the debriefing conversations. I mean, it's really nice that we do those every night, and the tenor, often we try and share our positive calls. There weren't very many positive calls, and that's hard. Even we have a thread of, we call it the kudos corner, where people post, good calls that they've had or pictures of their puppies or whatever. And there were a lot more pictures of animals than there were stories about good calls. And I think that just kind of all added up. And then fortunately, I happened to be in another meeting and Eric just said that word, grief. And it was like, wow, it's literally a light bulb came on for me. It's like, this is what's happening. We're all dealing with grief in a different way.
So that's how the dots came together for you. Yeah, great. Well, thank you. Yamaya, this question's for you. And, recognizing that we're trying to balance between taking care of employees and staff and leaders, self-care. I mean, that's a very delicate balance for sure. So you said be available and present. And that easily translates for leaders into 24/7, 365, which Becky touched on too as well. You have to have a beginning and end for some people, right? How do you recommend placing parameters around availability to support the leader's self-care?
Excellent question, and one that we coach leaders a lot around how to really set those parameters, because it's incredibly important to have boundaries. And when I discussed, just really being transparent with your employees about when you are and you aren't available, and when it's okay to contact via what means. So if it's via Teams or via text or via phone, or knowing exactly how to reach people when, and when you might say, between 6 p.m. or whenever it is onward, please only contact me in the case of an emergency. Just being really clear with people about when you have those boundaries, and it sets a good example for how they can have and hold boundaries as well. Even we remind some leaders say, well, I have to check email at night. Okay, but could you consider, even if you need to do that for your own peace of mind, maybe even having delayed response on your emails, so it's not setting the tone to everyone else, that the expectation is there for them to do the same. So we recognize leaders maybe do have a higher level of responsibility to be more available and accessible, and still boundaries are necessary.
Excellent, excellent. One of our participants remind us that we should share small wins at staff meetings and supervisions. That reminds me, yesterday, the division I'm in, we had our staff meeting and we started off with celebrations, recognitions, and small wins. And one of the things that I thought was pretty cool, the small wins, the small had a line through it, like crossing out. A win is a win. So great. And thanks for that insight, Aaron. Okay. I have a
Can I just say
question.
one more thing about that?
Yeah, please.
You know, in this environment, it's really easy to just be worried about, focused on problems all the time. And we have to intentionally shift our focus to what's working, because it's not going to be at the forefront of our minds. That's natural. And so it's not to ignore what's not working and what are the problems and challenges. It's both and. You guys know I'm a big fan of that. It's both seeing what are the challenges and being really intentional about turning towards what's working and highlighting it.
Yep, that sounds great. A question just came in that I want to ask you. Thoughts on how a team might raise the need for conversation of this nature with a team leader who doesn't think there's a problem and responds with hostility?
Ooh,
Ooh.
first of all, I'm so sorry if that's happening in any teams you all are a part of. I would approach it in a way where you really speak to your personal need and say, I'm feeling overwhelmed and I want to show up to work as well as possible. And I could really use some additional support. And here's my idea of what that could look like. We know the power of I statements. And if you connect it to your work and your desire to show up as well as possible to work, to get the work done, you're going to have a more, hopefully, a more receptive audience. I'm really sorry if that's the experience that anyone is not having. I would also, just let people know it's really normal. You could also normalize it for whomever you're talking to. It's really normal for teams to be getting additional outside support right now. The person Becky mentioned, Eric, he's actually from the state of Maine and the Strengthen Me program. So that's a program that's available to any frontline workers, and there's a part of it specifically for healthcare workers. They have a very broad definition of what a frontline worker is that is able to access free services. So I'd encourage people to go onto the Strengthen Me website and maybe make that available to your team leader and let them know many people are accessing this free resource.
And then you have a slide in our deck with a lot of resources on it, as I recall.
Yes, definitely.
Yeah. Okay, great. Thank you so much for that. Dr. Gass, this next question is for you. And this is actually a question from me. And this is my top of mind concern. So, I take in everything that goes on, and it seems like there's a disconnect with our general population relative to Omicron, vaccinations, boosters. It's just not connecting right from what I could see. So I think there's some misunderstanding out there about what the vaccinations and boosters can do. And so coming at that from a slightly different direction, I'll share a heartbreaking story with everyone just briefly and then ask you a couple of questions about it. Last week, my daughter-in-law called me on behalf of a coworker. Her father, in good health and in his 50s, was on a ventilator and in kidney failure due to COVID-19. She was desperately looking for options. Her father was unvaccinated. He died this week. What are you seeing with the severely ill people? Vaccinated versus unvaccinated? Are they all healthy people and the virus just evades the vaccines and boosters? Help us further understand why we should be vaccinated and get boosters if the virus can evade these. And I know you touched on that, but I think that's a central message to what we need to get out there these days.
Yeah, that's a tragic story. And
gosh.
unfortunately, we're seeing it played out every day.
And you're there taking care of these folks, correct?
I am. In fact, kudos to our ICU nurses and our critical care doctors, because they are bearing the brunt of this. And these stories like this are happening every day and more than once a day. I rounded in the ICU this morning, and I rounded in the pod that has our most critically ill patients with the team. And of the 8 patients in that pod, 7 were unvaccinated, and all were under the age of 70. And we're talking people from the age of 30 to 67. And the one person who was vaccinated was a very immunocompromised patient. So by far and away, the most severe illness that we are seeing is in the unvaccinated or in that group of people that can't mount an appropriate response. On the other hand, you are rolling the dice, even if you're an otherwise healthy person. You can still get severe disease, but again, it's much greater in those other groups. I think the 95% effectiveness of vaccines when they first rolled out sort of set unrealistic expectations. You know, vaccines' job is to prevent disease, and these vaccines prevent disease. And they're actually pretty darn good at preventing infection too. So I think all our expectations are sort of shrunk into this very short time period that we've never experienced in science before. But I can't stress enough, they're really quite good at preventing infection, and they're extremely good at preventing severe disease, hospitalization, and death. So I think we need to get vaccinated to protect ourselves, but we also need to think about the people around us. And we need to have a wall of vaccination to protect those people who won't mount a good immune response, the cancer patients, the patients on immunosuppression, the patient with uncontrolled HIV, the children who can't get vaccinated. And I think we need to get vaccinated to also prevent overwhelming our healthcare system and frankly, to keep our economy going. So there are lots of reasons for us to get vaccinated and boosted.
Yeah, and you know, I certainly chose the word carefully, a heartbreaking story. Heartbreaking in the sense, it seems like many of the people who end up in that circumstance, and certainly what we're hearing from nurses, you know, on their way to the ICU, they're saying, "Can I get the vaccine now?" And the answer is, well, it's too late at this point to handle what you're currently dealing with that's making you go to the ICU. And to me, that's heartbreaking. That's a preventable situation over 95% of the time, you know? So let's get vaccinated. It really is that simple to me.
The majority of the devastation that we're seeing in these intensive care units is preventable, in my opinion. I agree wholeheartedly, and vaccination and boosting is our major tool.
So I do have about 45 minutes more worth of questions for you guys, but unfortunately, we've come to the end of our session. We've included some excellent tools for you at the end of this presentation. Thank you all for joining us, and thank you to our panelists. I hope this hour has been a help to support you, your employees, and our communities to safely manage through this Omicron phase of the pandemic. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session, which I am really looking forward to, will be on February 10th. We'll be discussing the latest on COVID-19 and frontline experience from several different businesses focused on working through the pandemic with employees, and ample time to answer all of your questions. This session will be a very informative learning experience for all of us. We will send you the link for this session. We encourage you to share the invitation with your friends and colleagues. By working together to promote good health, we will be promoting good business. Thank you, have a good afternoon, and stay safe.